Good morning, student. Today's lecture is on the venous drainage of the lower limb. Competencies for the today's lecture are: describe the venous drainage of the lower limb, give the anatomical basis of varicose veins, deep vein thrombosis, elephantitis, and venesection of great saphenous vein in front of the medial malleolus. Consideration of the venous drainage of the lower limb is important because in the lower limb, venous blood has to ascend against the gravity. Also, it is important to understand pathogenesis, diagnosis, and surgical treatment of varicose veins. Venous drainage of the lower limb is helped by various factors, and these factors are categorized into two: general factors and the local factors. General factors are negative intrathoracic pressure, arterial pressure, and overflow from capillary bed. Compression of veins accompanying arteries by a pulsation. Presence of walls. They support the long column and maintain the unidirectional flow. So, general factors are negative intrathoracic pressure, arterial pressure, and overflow from the capillary bed. Compression of veins accompanying arteries by a pulsation. You know venacomites. So venacomites are the veins which runs along the main arteries. Okay, and so the arterial pulsation helps compress these veins. Presence of walls. The presence of walls supports the long column of the blood and it maintains the unidirectional flow of blood. Coming to the local factors are divided into three parts: venous factor, muscular factor, and the fascia. Veins of the lower limb are more muscular and they have greater number of walls. Superficial veins are connected to the deep veins by the perforators or the perforating veins. Muscular factor. Contraction of the muscle compresses the deep veins and drives the blood upwards. Fascia of the lower limb forms a tight sleeve and makes the muscular contraction of the veins more effective. So these are the factors which help in the venous drainage of the lower limb. Coming to the veins of the lower limb, they are classified into three groups: superficial veins or the subcutaneous veins, deep veins which accompany the arteries and located deep to the deep fascia. Perforating veins, they are also known as the perforators. They connect the above two. That means they connect the superficial veins with the deep veins by passing through the deep fascia. In this diagram, you can nicely appreciate the superficial veins, deep veins, and the perforators. Superficial veins are, this is the dorsal venous arch, here is the long saphenous vein, and here is the small saphenous vein. And deep veins are femoral vein, posterior arch vein, posterior tibial vein, peroneal vein. And these violet color, they are the perforators, which connects the superficial vein with the deep vein. Okay. Superficial veins lie in the superficial fascia and superior to the on the superior surface of the deep fascia. Characteristic features of the superficial veins are: these veins are thick-walled, they have numerous walls in the distal part, and large part of blood drains into the deep veins by the perforating veins. So these are the three characteristic features of the superficial veins. Superficial veins are dorsal venous arch on the dorsum of the foot, great saphenous vein, small saphenous vein, and their tributaries. Dorsal venous arch. It is located on the dorsal part of the metatarsal bone. Here is the dorsal venous arch, which is located on the metatarsal bone here. It receives dorsal digital and the dorsal metatarsal veins. So these are the dorsal digital and the metatarsal veins which joins to the dorsal venous arch. Along the sides of the foot, there are medial and the lateral marginal veins. From the side of the foot, there are medial marginal and the lateral marginal veins. They drain the dorsal and the plantar aspect of the respective sides into the dorsal venous arch. So the lateral marginal vein and the medial marginal vein joins with the dorsal venous arch. The medial end of the arch, that is the dorsal venous arch, along with the medial marginal vein, continue as a great saphenous vein. So the medial marginal vein joins with the medial end of the dorsal venous arch and continue as a great saphenous vein or the long saphenous vein. The lateral end of the arch along with the lateral marginal vein continue as a small saphenous vein. So here is the lateral marginal vein along with the lateral end of the dorsal venous arch. They join and they will form the small saphenous vein. Great saphenous vein. It is the longest vein in the body. Morphologically, it represents the pre-axial vein of the lower limb. It is formed by the medial end of the dorsal venous arch and the medial marginal vein. They unite to form the long saphenous vein or the great saphenous vein. So the great saphenous vein is formed by the joining of the medial end of the dorsal venous arch and the medial marginal vein. Okay. Termination. It terminates in femoral vein, 3 cm below the inguinal ligament and below and lateral to the pubic tubercle. Here. So the great saphenous vein will terminate in the femoral vein, 3 cm below the inguinal ligament and below and lateral to the pubic tubercle. Course of the great saphenous vein. After its formation, it ascends upward. At the ankle, it enters the leg at a very constant point. It ascends between the medial malleolus and the tendon of the tibialis anterior. It lies 2.5 cm in front of the medial malleolus. Here is the medial malleolus and it lies 2.5 cm in front of the medial malleolus. Then it remains in contact for a short distance with a distal third of medial surface of the tibia. And here it is accompanied by the saphenous nerve. This relation is very clinically very important. So in the beginning, it is accompanied by the saphenous nerve. Further, it ascends along the medial border of the tibia to reach the posterior aspect of the medial side of the knee. At the back of the knee, it is about a hand's breadth behind the medial border of the patella. Here is the patella and it is at the hand's breadth behind the medial border of the patella. In the thigh, the vein ascends upward along the medial aspect of the front of the thigh until it reaches the saphenous opening here. Finally, it passes through the saphenous opening and pierces the cribriform fascia and terminates in the femoral vein. So it will be a great saphenous vein will pierce the cribriform fascia and opens into the femoral vein. So here you can see the course of the great saphenous vein. So it is formed by the medial end of the dorsal venous arch and the medial marginal vein. Then it will ascend in the leg in front of the medial malleolus. Then it will pass slightly behind to the the thigh, and then it will enter into the thigh and open into the femoral vein at the saphenous opening. So here is the surface marking of the saphenous vein, great saphenous vein. Relations in the foot in front of the medial malleolus and in the leg accompanied by a saphenous nerve which is in front of it. So the saphenous nerve lies in front of the great saphenous vein. On the medial side of the knee, it is related to the saphenous branch of the descending genicular artery and the saphenous nerve. In the thigh, it is accompanied by a branch of the medial femoral cutaneous nerve. So these are the important relation of the great saphenous vein. Coming to the tributaries of the great saphenous vein, at the ankle, medial marginal vein from the sole, just below the leg, posterior arch vein, anterior leg veins are there. Above the knee, anterolateral vein begins from a venous plexus on the lower part of the front of the thigh. Posteromedial vein, which is also known as the accessory saphenous vein, it joins the great saphenous vein. Here is the anterolateral vein. So these are the tributaries of the great saphenous vein. Just before piercing the cribriform fascia, it receives the superior epigastric, superior circumflex iliac vein, superficial external pudendal vein. And just before the termination, it receives the deep external pudendal vein. Thoracoepigastric vein runs along the anterolateral wall of the trunk. It connects the superficial epigastric and the lateral thoracic vein. So it form a communication between the femoral and the axillary vein. So it is an important communication between the superior vena cava and the inferior vena cava. So thoracoepigastric vein, which runs along the anterolateral wall of the trunk. It connects the superficial epigastric vein. That means ultimately it is connected with the great saphenous vein and the lateral thoracic vein. So it forms a communication between the femoral and the axillary vein. So it is important communication between the superior vena cava and the inferior vena cava. Walls, 10 to 20 number of walls are present in the great saphenous vein. They are more in the leg than the thigh. Two are in fixed position. One when the vein pierces the cribriform fascia, and another is just at the point of termination in the femoral vein. So these two sites are constant and rest are distributed in the at different levels. Small saphenous vein. It begins behind the lateral malleolus as a continuation of the lateral marginal vein, or it may form by the union of the lateral marginal vein and the lateral end of the dorsal venous arch. It terminates in the popliteal vein. So here it terminates in the popliteal vein. It shows variable termination. It may join great saphenous vein, the upper part of the thigh. It may sometimes directly joins with the great saphenous vein in the upper part of the thigh. It may split and one joins with the great saphenous vein and another one join with the popliteal vein or the deep posterior vein. Sometimes it may end in the great saphenous vein below the thigh or in the deep muscular veins. So small saphenous vein shows variability in its termination. It may join the great saphenous vein in the upper part of the thigh, or it may split and one will join with the great saphenous vein, another will join with the popliteal vein and the deep posterior vein. And sometimes it may end in the great saphenous vein below the thigh or in the deep muscular veins. Course and relations of the small saphenous vein. After origin, it runs upward behind the lateral malleolus, then along the lateral side of the tendoachelis. Here is the tendoachelis. Then it will run along the lateral side of the tendoachelis, then the middle of the till the middle of the back. Then it perforates the deep fascia and passes between the two heads of the gastrocnemius muscle in the lower part of the popliteal fossa and terminates in the popliteal vein. Okay, and it is accompanied by the sural nerve in the leg. Great saphenous nerve is accompanied by the saphenous nerve, and the small saphenous vein is accompanied by the sural nerve in the leg. Tributaries of the small saphenous vein. At the ankle, it receives the vein from the sole and the dorsum of the foot. Several cutaneous tributaries of the leg. Communication from the great saphenous vein. Perforating veins may connect it to the deep veins of the calf. This small saphenous vein contains 7 to 13 number of valves. One is constant at the termination. Coming to the deep veins of the lower limb, they show certain characteristic features. They accompany the arteries and their branches are vena comites. So the deep veins, they accompany the arteries and their branches are the vena comites. Usually run deep to the muscles and are supported by the surrounding muscles. Walls are more than the superficial veins. They communicate with the superficial veins by the perforating veins or the perforators. Due to the driving force of the muscular contraction, they form the efficient channel for the venous blood. So these are the characteristic features of the lower limb. They accompany the arteries. Usually they run deep to the muscle and they are supported by the surrounding muscles. More walls are present in the deep veins as compared to the superficial veins. Deep veins communicates with the superficial veins by the perforators. And due to the driving force of the muscular contraction, they form the efficient channel for the venous blood. Deep veins, they are venicomites. They accompany the deep arteries of the leg. These venicomites unite to form the popliteal vein in the popliteal fossa. Popliteal vein passes through the adductor hiatus and it will enter in the femoral triangle, and here it will continue as a femoral vein. And the other communicating veins are anterior and the posterior tibial veins, peroneal veins. So these are the deep veins: popliteal vein, femoral vein, anterior and the posterior tibial veins, and the peroneal veins. Coming to the perforating veins or the perforators. They are communicating venous channels between the superficial and the deep veins here. So perforating veins are nothing but the communicating channels between the superficial and the deep veins. Perforating veins or the perforators, they direct the blood from the superficial to deep veins. They perforate the deep fascia, therefore they are known as the perforators. Here is the deep fascia, you can see green line, and these are the perforators. They perforate the deep fascia, therefore they are known as the perforator. Characteristic features of the perforators are, they are provided with the valves which direct the blood in one direction. There are two types of perforators, direct perforators and the indirect perforators. Indirect perforators, they connect the superficial veins with the deep veins through the muscular veins. So here is the soleus muscle which contains the sinuses, and these sinuses, they through the sinuses, the deep veins and the superficial veins connected through the perforators. Okay. Direct perforators, they connect the superficial veins with the deep veins directly. In this diagram, you can nicely appreciate that the superficial veins and deep veins, they are connected with each other directly. Here there is a sinuses in between present. Therefore, they are indirectly connected with each other. So the perforators are of two types, indirect perforators and direct perforators. Okay. Number and size of perforators. In the thigh, there is adductor canal perforator, which is also known as the Dodds perforator, which connects the great saphenous vein with the femoral vein. Okay. Below the knee, there is a 1 minute. Here is the adductor canal perforator, which is also known as the Hunter's perforator, which is present in the Hunter's canal or the adductor canal, which connects the small great saphenous vein with the femoral vein. Here is the femoral vein. Here is the long saphenous or the great saphenous vein, and in the adductor canal, these two veins are connected by a perforator, and that perforator is known as the Hunter's perforator or the adductor perforator or the Dodds perforator. Okay. Below the knee, there is a Boyd's perforator here. Below the knee, again the great saphenous vein is connected to the posterior tibial vein, and that is known as the Dodds perforator, Boyd's perforator or the Sherman's perforator. Here is the name, Boyd's or the Sherman's perforator, which connects the great saphenous vein to the posterior tibial vein below the knee. That is the Boyd's or the Sherman's perforator. Okay. In the leg, there is upper lateral perforator at the junction of the middle and the lower 1/3 of the leg on the lateral side of the leg, which connects the small saphenous vein with the peroneal vein. Here is the small saphenous vein and here is the peroneal vein, and it is connected by the lateral perforator. So in the leg, the first perforator is the lateral perforator. Between the medial malleolus and the mid-calf, there are 3 ankle perforators on the medial side of the leg, connects the posterior arch vein to the posterior tibial vein, which indirectly connects the great saphenous vein with the deep veins of the leg. So these are the 3 medial ankle perforated, 1, 2, and the 3, which connects the posterior arch vein with the posterior tibial vein. Okay. They are known as the Cockett's ankle perforator. Here, 1, 2, and 3. The upper one is present at the junction of the middle and the lower 1/3 of the tibia. Lower one is present below and behind the medial malleolus, and the middle one is present between the upper and the lower, which is about 10 to 13 centimeter above the tip of the medial malleolus. So these sides are fixed. So there are 3 Cockett ankle perforators, upper, lower, and the middle. Upper, lower, and the middle one. Okay. Importance of this perforator: when the walls of these perforator veins become incompetent, blood will flow from deep to superficial veins and give rise to dilatation, tortuosity, and engorgement condition of the superficial veins, and this is known as the varicose vein. This is the normal position. When the walls are deficient, then the superficial veins become dilated, tortuous, and engorged. Okay. Factors helping the venous return of the lower limb. Contraction of the calf muscle squeezes the blood upward along the deep vein. The calf muscle acts as a calf pump. Presence of walls in the vein in perforating veins prevent the reflux of the blood into the superficial veins during the contraction of the calf muscles. Presence of walls in the deep veins supports the column of the blood and maintains the unidirectional upward flow of blood. Transmitted arterial pulsations, especially in the vena pomites of the arteries, they are also one of the important helping factor for the venous return of the lower limb. Musculovenous pump. Contraction of the large muscles within the tight facial compartment compresses the deep veins and force the blood up in the limb. So here are the muscles which are present in the tight facial compartment, and when they contract, they will force the blood towards the heart. Superficial veins are not subjected to these high pressure compression forces. Walls in the perforateds prevent the high pressure venous blood being forced into the low pressure superficial veins. As the muscles within tight facial compartment relaxes, venous blood is sucked from the superficial to deep veins. So here you can nicely appreciate, here is the bone, here is the deep fascia, here is the muscular belly, and this is the deep vein. Here is the superficial vein, and this is the perforating vein. When the muscles are relaxed, naturally the blood will flow from the superficial veins into the deep veins. Again, this is one picture showing the connection between the deep veins and the superficial veins, and this is the perforating veins or the perforators. Peripheral heart. Soleus is known as the peripheral heart. Remember, this contains large sinuses filled with the blood. Here is the soleus muscle, and these are the sinuses which are present in the soleus muscle, and they are filled with the blood. During the contraction of the soleus muscle, it pumps out blood from the sinuses to the deep veins. And when it is relaxed, it sucks the blood from the superficial veins, and thus refilling of the sinuses occurs. So naturally, when the soleus muscle will contract, it will push the blood from the sinuses into the deep veins. And when the soleus muscle is relaxing, that time the blood is sucked from the superficial veins into the sinuses. So naturally, it acts as an indirect perforator. So here is the skin, then the superficial veins. Here is the deep fascia. This is the perforators or the perforator. Then this is the muscle which contains the sinuses, and these are again perforators. So in between the two perforators there are sinuses there, and therefore it is known as the indirect perforator. Okay. Coming to the clinical anatomy of the lower limb, venous system of the lower limb. The great saphenous vein is often chosen for the venous cut in the emergency. During this procedure, care should be taken not to injure the saphenous nerve. We know that the saphenous nerve runs along with the great saphenous vein. So care should be taken not to injure the great saphenous nerve. This venesection usually performed at the ankle. Therefore, it is known as the ankle vein cut down. So here is the medial malleolus, and here is the great saphenous vein. Okay. And usually the cut is done in this region. Here is the procedure. Splint लगाया हुआ है. And here is the great saphenous vein, and here is the cut taken for the venesection. Great saphenous vein is used for coronary arterial bypass because it is more muscular as compared to the rest of the veins in the body. Vein segment is reversed to prevent the obstruction by the walls. So Here is the segment of the great saphenous vein is put in the heart. Okay. Deep vein thrombosis, which is also known as the phlebothrombosis. It is a condition in which a blood clot is formed in the deep veins of the body. There are various causes for the deep vein thrombosis. Sitting for a long time. If one has a medical condition affecting the normal clotting of the blood, it is the most feared complication of after the surgical operation, because after surgical operation rest is given, and because of that there may be stagnacies of the blood in the lower limb and emboli may be formed. So deep vein thrombosis is the condition in which the blood clot is formed in the deep veins of the body, and there are various causes for the deep vein thrombosis. Sitting for a long time, especially when there is a long aeroplane travel. If one has a medical condition affecting the normal clotting of the blood, it is the most feared complication of after the surgical operation. During the post-operative period, there is minimum activity of the legs, which favors the venous stasis and thrombosis, and therefore nowadays the patients are ambulated very early. The emboli from the thrombus enter the venous circulation to reach the right side of the heart and may cause the life-threatening pulmonary embolism. That is the consequence of the thrombus formation. There are factors which cause the deep vein thrombosis, and that is known as Virchow's triad. Virchow described three factors responsible for the deep vein thrombosis. First one is venostasis, the second one is hypercoagulable state, and third one is vessel injury. Venostasis may occur because of the prolonged bed rest after surgery or after paralysis, or the cast on the leg because of the fracture. Then hypercoagulable state, which may be present because of the surgery, pregnancy, or the trauma. Vessel injury, there is endothelial damage and which leads to the formation of the deep vein thrombosis. Varicose veins. Normal flow of blood in the venous system depends upon the presence of competent walls which prevent the reflux. When the venous walls become incompetent, they tend to place extra pressure on the more distal walls, which may also become incompetent. This condition produces dilated tortuous superficial veins, and that is known as the varicose veins. So, normal flow of the blood in the venous system depends upon the presence of competent walls which prevent the reflux of the blood. When the venous walls become incompetent, they tend to place extra pressure on the more distal walls, which may also become incompetent. And this condition produces dilated, tortuous superficial veins, and it is known as the varicose veins. So in the diagram, you can see these are the dilated, tortuous veins. That is the varicose vein. Causes: prolonged standing position, especially it occurs in the nurses, traffic police, bus conductors. Lack of power of calf muscles. Some individuals have genetic predisposition to develop the varicose vein. Incompetency of the walls. If the walls in the perforating veins are incompetent, there will be reversal of the blood flow from the deep to the superficial veins, leading to the dilatation of the superficial veins. If the saphenofemoral wall is incompetent, there may be flow of blood from the femoral to the great saphenous vein. So in this diagram, you can see this is a healthy vein. Okay. Here the walls are closing. This is the picture of the varicose vein, where here is the damaged wall. Okay. Complication: thrombophlebitis and varicose venous ulcer. So Here you can see the varicose venous ulcers. So in the varicose vein, initially there is bulging of the veins. Then along with that, there will be leg swelling. Then there will be change in the skin color and the texture. Then there is a venous ulcer, formation of the venous ulcer. So these are the stages of the formation of the venous ulcer. Saphana varix. It is a saccular dilatation of the terminal part of the great saphenous vein. So great saphenous vein ends in the femoral vein. So just below the inguinal ligament. So you will get the saphana varix lateral to the lateral and below 3 to 4 centimeter below the pubic tubercle, where you can get also the one condition that is known as the femoral hernia. So you have to take care the differentiate between the femoral hernia and the saphana varix. So here you get the saphana varix. It is usually accompanied by other signs of varicose vein. This saphana varix or this swelling is accompanied by the varicose veins. It disappears when the patient lies flat. A venous hum can be heard when a stethoscope is applied over the saphana varix. So saphana varix is a condition where the saccular dilatation of the terminal part of the greater saphenous vein occurs, and we know that the greater saphenous vein terminates into the femoral vein just below 3 to 4 centimeter below the inguinal ligament. Okay. So you have to differentiate between the saphana varix and the femoral hernia. Venous. It is a peristaltic pump. It is a compact battery operated peristaltic pump that generates a wave from motion. When it is worn firmly on the calf using the adjustable Velcro straps, the device produces upward volumetric displacement, which translates to an increase in the venous and the lymph flow. Pumping action reduces the swelling, pain, and other symptoms. So here is the Venous wave, which is given for the patient of the varicose vein. Elephantitis. It is a condition characterized by a gross enlargement of an area of the body, especially the limbs. Other areas commonly affected include the external genitalia. So here you can see the picture of the elephantitis, and sometimes the external genital swelling is there. It is caused by the obstruction of the lymphatic system, which results in the accumulation of fluid called the lymph in the affected area. So lymphedema is there. Obstruction of the lymph vessel first result in the lymphedema and then can slowly progress to massive swelling and gross enlargement characteristic of the elephantitis. In areas where the filariasis is endemic, the most common cause of elephantitis is a parasitic disease known as the lymphatic filariasis. And the term lymphatic filariasis and the elephantitis should not be used interchangeably. There is difference between the two. The swelling occurs because of the obstruction of the lymph vessels, and this occurs because of the filarial paralysis. And that term swelling of the lower limb is known as the elephantitis. So these two terms are not common. In the most areas, lymphatic damage associated with the elephantitis has other causes, including the certain sexually transmitted diseases, tuberculosis, repeated streptococcal infection, leprosy, and environmental factors such as exposure to certain minerals, that is silica. In some cases, no cause can be identified, that is known as the idiopathic elephantitis. Okay. So there are other causes are also present for the elephantitis, like sexually transmitted diseases, tuberculosis, repeated streptococcal infection, leprosy, environmental factor, and sometimes you may not find any cause for that. That time it is known as the idiopathic elephantitis. Okay. So this is all about the venous drainage of the lower limb. You may get full question on the venous drainage of the lower limb, and so many short notes are there, like great saphenous vein, small saphenous vein, perforators. Okay. Then deep vein thrombosis, varicose vein, clinical questions on the varicose vein, deep vein thrombosis, elephantitis. In this way, you will get the question during the examination. Thank you.